Thank you very much, Dr. Kalembi, for this opportunity. I'd also like to congratulate the Kenya Renal Association for an excellent online congress. Is something new and something that has truly been a good replacement for what we normally have. Today, I'll talk about vaccination in chronic kidney disease. So infection is a major cause of morbidity and mortality in chronic kidney disease in patients on maintenance hemodialysis, in chronic peritoneal dialysis, and in the kidney transplant patients. The responses to vaccines are impaired in these populations. Immunizations remain an important component of preventive care because of favorable safety profiles and high rate of infection in these patients. There's a relatively low antibody response to a vaccine and appears to correlate with the degree of renal failure, but not with a specific mode of dialysis. It appears that disturbances in T lymphocytes and antigen-presenting cells may be responsible for the altered acquired immunity in end-stage renal disease patients, but additional studies need to be carried out. So most guidelines for patients with chronic kidney disease focus on hepatitis B, influenza vaccine, pneumococcal vaccine, and other age-related and age-appropriate immunizations. We need more data to determine the clinical efficacy of these immunizations and the optimal dosing and timing for administration. This is an area studies have suggested that there may be benefits to immunization before the onset of dialysis or transplantation, because patients with early stage chronic kidney disease generally have higher rates of seroconversion. So those patients you're seeing in the clinic with early stage chronic kidney disease, that is the time to vaccinate them. Don't wait until they're in end stage and they're going on to transplantation before you think about it. Please start thinking of it early. This we talk about every day, but the practice seems to be very different from what we talk about. So my appeal in this meeting is to ensure that our practice follows the teaching so that we up our game in this particular respect. Because nephrologists often serve as primary care physicians for patients with chronic kidney disease, it is important to understand the role of vaccination in the preventive care of this patient population. So these are some of the vaccination recommendations. Hepatitis B, the age, the dose, and the schedule as shown, and the need for booster doses. The pneumococcal vaccine is shown there, influenza vaccine for the different age groups. We'll discuss more about the varicella, hepatitis A, and measles, mumps, rubella, and inactivated poliovirus, together with the diphtheria and tetanus toxoids. The hepatitis B vaccination in chronic kidney disease is recommended for all patients, and this I have to emphasize because, as I said, the practice is very, very far from what we teach. Patients with uremia who are vaccinated before they require dialysis have higher seroprotection rates and antibody titers. The response to vaccination is also better in children. The dosage and schedules, we need higher vaccine dosages or an increased number of dosages recommended for patients who have chronic kidney disease with an estimated GFR of less than 30. Patients should receive 4 doses of hepatitis B vaccine as early in the course of the disease as possible. Recombinant hepatitis B vaccine is recommended. We use special formulations of vaccines or 20 microgram doses given at one site. The dosage schedule should be 0, 1, 2, and 6 months, not the 3 dosages, but the 4 dosages are important. Vaccines should be given intramuscularly in the deltoid region. I should also assess antibody titers to hepatitis B surface antigen. The anti-hepatitis B antibody is important in assessing the need for boosters. The first titer should be done 1 to 2 months after the primary course is completed and annually thereafter. So really, this should be a routine activity in every renal unit, the regular assessment of the antibody titers in the patients. The booster dosages should be given if the anti-hepatitis B antibody titers fall below 10 microunits per mil. Vaccination with full dose is recommended for persons who do not develop protective antibody titers and the primary cause. We move to higher dosages once dialysis starts during the vaccination. The prevalence of an incidence of hepatitis B infection is high at about 7.6 prevalence and 3.6% incidence, respectively, among the dialysis population in our region. The vaccine provides effective protection against the infection, and vaccination in early stages of CKD has better seroconversion rates than in late vaccination. There's no difference in seroconversion rates in recombinant and plasma-derived vaccine, but of course, the different companies will make different claims. But recombinant vaccine is preferred due to the fear of disease communication with the plasma-derived vaccine. So that's a theoretical advantage. So we need the double dose, 40 micrograms, and 4 doses giving a better seroprotection, 73 to 92%, compared to 45 to 67% with the conventional 3 doses schedule. We've mentioned the area of administration being the deltoid region. Intradermal administration has no advantage over intramuscular administration. Antibody titers fall with time in patients on dialysis and therefore necessitates annual monitoring. The vaccine has been shown to be safe for patients on dialysis with only minor local reactions, including pain, redness, or swelling at the vaccination sites. There's an increase has been reported in anti-hepatitis B antibodies responses with co-administration of zinc as a coadjuvant, erythropoietin, immunomodulators such as alpha and gamma interferon, thymopentin, interleukin-2, granulocyte macrophage colony stimulating factor. And such approaches should be reserved for patients in whom it is difficult to achieve seroconversion with at least 2 courses of the vaccination. So adjuvants are there, but they have not become very popular because of the fear of reaction, particularly rejection. The pneumococcal vaccine, the burden of the pneumococcal infection in chronic kidney disease patients is high. The cost of pneumococcal vaccination is low as compared to the global health costs in this population. So that recurrent admission due to pneumonia will be completely avoided by giving this simple and very effective vaccination. These readmissions, of course, are very costly for those of us who have been long in the field of nephrology, and is easily avoided. That is the simplicity of the matter, the easy avoidance of these serious diseases that are common in our environment. There are no data indicating potential disadvantages of the pneumococcal vaccine. Pneumococcal vaccination should be administered to patients with chronic kidney disease as early in the disease as possible. The ACIP schedule recommends PCV13 prime vaccination, followed by PPV23 vaccination, as shown. So this is a table showing the different administration of the different vaccines, the different age groups. It's a busy slide, so I won't belabor the point. You'll be able to go through it later. The influenza vaccine is important. Dialysis patients are at increased risk of influenza-related mortality. This cuts across all the age groups on dialysis, but particularly the elderly. So there's a 4-fold increase in serum antibody titers against influenza antigens have been observed in 50% of dialysis patients compared to 40% of healthy controls. There are no systemic reactions reported following influenza vaccination in dialysis patients. So please urge your patients to get this dialysis done. I keep repeating this plea because my experience, particularly in Kenya, is that we tend to be a bit relaxed in this area. So let this be a clarion call to all the nurses, all the nephrologists, everybody in the area of dialysis for chronic kidney disease to ensure that these vaccines are given. The influenza vaccine is given annually before the beginning of the influenza season for persons 6 months of age or older on dialysis. Household contacts and healthcare workers should also be vaccinated annually to decrease the transmission to these high-risk CKD patients. So that's one thing we always forget, the need for vaccination of household contacts. The vaccine dose is 0.25 mils by intramuscular routes for those between the ages of 6 and 35 months, and 0.5 mils thereafter. Again, for the dosing for the younger age groups. Live vaccines are completely contraindicated in immunocompromised patients due to the risk of vaccine-induced infections. Limited numbers of studies in CKD patients have not shown any adverse reactions, though. But nevertheless, these vaccines should be avoided by all means, with the exception of varicella and MMR vaccines, because of the severity of these infections in these patients. So one could risk with varicella and MMR, but all the others, the yellow fevers and all those, should not be considered at all, because they're live vaccines in these immunocompromised patients. The varicella vaccine is high risk. There's a high risk of complications and death associated with chickenpox infection in adulthood. About 85% of children on dialysis develop protective antibodies levels within 6 months following a single dose of the vaccine. The varicella vaccine has been reported to be safe for children on dialysis, and the MMR vaccine should be given to all children, including those on dialysis between 12 and 15 months of age, with booster doses between 4 and 6 years of age. There is use of inactivated vaccines and toxoids. All inactivated vaccines, this is in not live vaccines, but inactivated vaccines and toxoid are safe and effective when used in dialysis patients. They should be administered to children and adults on chronic dialysis, and the same doses and schedules recommended for immunocompetent persons. We have other vaccines which we normally give to children. Haemophilus influenza, diphtheria, tetanus toxoid, etc. Just to mention that hepatitis A vaccine is highly immunogenic in children, adolescents, and adults. Up to 100% of recipients develop protective levels of antibodies, more than 20 micro units per mil, persisting for up to 48 months. So these are important vaccinations. So that was vaccination in chronic kidney disease patients. Now let's look at vaccination in the transplant patients, which holds a few differences here and there. I'd like to highlight some of the timeline of post-transplant infections. We have the infections that occur in the first less than 4 weeks. These are mostly nosocomial infections, and in the donor and the recipient. So basically, antimicrobial resistant species like MRSA, like vancomycin resistant Staph aureus, like Candida species, etc. Mostly got problems of aspiration, line infection, wound sepsis, etc. Then there are the infections that we get between 1 month and 6 months in the solid organ transplantation recipients. And these are infections like pneumocystis, pneumocystis, pneumonia, and antiviral CMV, hepatitis B virus. So we did prophylaxis, the BK, the polyomavirus, Clostridium difficile, hepatitis, etc. This is when the patients get such infections. Then the infections that occur after 6 months following transplantation. These are mostly community-acquired pneumonias, urinary tract infections, aspergillus, typical molds, and mucormycosis, and others. CMV also comes in here. BKB, hepatitis B, also come in here. So the knowledge of the timing of these infections is important because many of these are vaccine preventable infections, and hence the need for seriously considering vaccination in the patients preceding transplantation. The important things to note: the patient's ability to mount an infective response after immunization and reduce the risk of infection after vaccination depends on the patient's net state of immunosuppression. The greater the degree of immunosuppression, the less likely the patient is to respond to immunization. The factors contributing to immunosuppression in this setting include the underlying disease, be it renal, hepatic insufficiency, the presence of allograft rejection, immunosuppressive therapy administered after transplantation. So, potent immunosuppressive regimens means that these patients are at higher risk of infection, including vaccine preventable diseases. So the issues of potent immunosuppression is the reason why we really have to vaccinate these patients before. Assessing the need for and providing appropriate vaccination can greatly reduce the infectious complications associated with renal transplantation. The fear of toxicity or allograft rejection might also contribute to the low vaccine uptake, so that you sort of fear that the patient may lose the kidney, but oftentimes this fear is unfounded, and you must go right on and ensure that the patient is vaccinated. The transplant recipients are usually excluded from trials, leading to a scarcity of data regarding their safety and efficacy in these patients. Hence, we have an incomplete and unavailable information on vaccination, their safety, their optimal timing, the vaccine efficacy. But several guidelines have emerged based on individual case series and experience with other immunocompromised patients. The general principles is that the immune system, because of immunosuppression, will not be able to mount an effective response as in the normal subjects. So the mechanisms come into play: impaired B and T cell response, interference with purine synthesis resulting in blockage of both T and B cell proliferation, post-transplant hypogammaglobulinemia, and the waning natural immunity and impaired de novo antibody response. So KDIGO, of course, has come up with guidelines, came up in 2009, the comprehensive evidence-based guidelines for care of kidney transplant recipients, including vaccination. They said transplant recipients should receive age-appropriate inactivated vaccinations as recommended for the general population. And hepatitis B should be guided by the HBS titers, measured at least 3 months after completion of vaccination and annually thereafter. The KDIGO says kidney transplant recipients should not receive live vaccines, as we have mentioned already. If a patient has received a live vaccine, the transplant should be delayed by at least 4 weeks since the time of the administration of the live vaccine because of the danger of immunosuppression. KDIGO says kidney transplant patients should receive ancillary inactivated vaccines based on the risk factors for the respective disease and the propensity to develop these rare infections, especially for vaccines that are neither routinely recommended to the general population nor specifically in transplant recipients. KDIGO further says, in general, it's best to wait until the first 3 to 6 months after kidney transplantation, and because this is the period of intense immunosuppression before attempting vaccination. However, we said inactivated influenza vaccination can be administered as early as 1 month after kidney transplant to time it before the onset of the flu season. If the flu season is around the corner, then you are allowed to give it in that situation. These are some of the rationales Suffice it to say that we must have a proper pre-transplant vaccination history and the seroprotective status, which would affect the post-transplant vaccination strategies. Very important. So I'd really like vaccination. Again, I'm referring to the Kenyan situation, to become a major issue in the pre-transplant preparation and also in the chronic kidney disease clinics, so that these things are addressed early. Because when they're addressed early, you're able to have a far greater effect on the patients than otherwise. So detailed vaccination history should be obtained in all patients. The vaccination strategies include timing of the vaccination, the use of immunoadjuvants, the live vaccines versus inactivated vaccines, the monitoring of antibody titers, and monitoring for and managing rejection crisis when it arises. I've alluded to these already, so but suffice it to say that the optimum time for primary vaccination is the pre-transplant phase due to variable serological response rates. The immune response to vaccines is decreased in the patient with end-stage renal disease. So the alternative is more than 6 months after transplantation to permit sufficient time for the doses of immunosuppressive drugs to stabilize and for the immune system to recover. Again, part of the timing, we have alluded that to vaccination too close to transplantation may also result in ineffective protection. So an initial reduction in antibody titers immediately after vaccination has been described in children. Again, more about the timing, which we have alluded to already. So primary immunization before transplantation allows use of all types of vaccines, including live vaccines, achieving adequate antibody titers, and managing possible vaccine-related reactions without compromising graft outcome. Immune responses are suboptimal during the period of intensive immunosuppression, as we have said already. Again, more about timing of the vaccine. The 3 to 6 months at a period of intensive immunosuppression to avoid a vaccination. Immunoadjuvants, we have alluded to them in the setting of chronic kidney disease and vaccination. So the data on immunoadjuvants mainly comes from hepatitis B vaccines. Interferon and interleukin-2 were used in the 80s as adjuvants in low responders to hepatitis B vaccine. Interleukin-2 in particular was used in uremia patients with 70% seroconversion without major side effects. Other adjuvants include aluminium compounds, the hormone dihydroepiandrosterone sulfate, and several cytokines, GCSF being the adjuvants to enhance the efficacy of the uptake. Other adjuvants, more recently, MF59 has been used together with hepatitis B virus vaccine in normal adults with promising results. There are no data available in immunocompromised patients for these compounds. The safety of immunoadjuvants in patients post-renal transplant has yet to be established, and the risk of rejection directly caused by immunoadjuvants needs to be excluded. And so indeed, the area of immunoadjuvants has not taken on very strongly, but we need more studies in this regard. Live attenuated vaccines pose considerable risk of unchecked vaccine strain proliferation and vaccine-induced diseases in the transplant patients. Live virus vaccines should be administered as early in the course of chronic kidney disease as possible, at low GFR, but ensure that the chronic kidney disease will progress on towards end stage. So do it early. After administration of a live attenuated vaccine, a mandatory minimum waiting period of 4 weeks is necessary before using immunosuppression. Monitoring the immune response is important in terms of checking for seroconversion, which will be documented after 4 weeks of completing the course of immunization to ascertain adequacy of protection and determine need for additional boosters. So while on ongoing immunosuppression, it may be prudent to monitor protective antibodies levels to time booster doses appropriately and monitor cellular immunity for protection against infection is under research. So this is more on the need for vaccination of health workers and household contacts. Don't forget that these household contacts will also give the transplant patient these diseases. So they also need to be vaccinated, including the pets. This is important where you can. So don't forget the veterinarian for your pets to ensure that this transplant recipient is fully protected. The household contacts, as I said, care should be taken to avoid live vaccines for household contacts. Because if you give live vaccine to the contact and the transplant patient is there, of course he will get it because of viral shedding, which will occur. So it is important for the household contacts to also practice safe hand washing and all these things that have come in this era of COVID. So the hand washing, limit contact with the transplant recipient for the first 2 weeks because of the issues of viral shedding that will occur in the household contacts and the healthcare workers. The monitoring of antibodies, we have alluded to already, extremely important so as to be able to give boosters as appropriate. So monitoring of post-vaccination titers is commonly done for hepatitis A and B. The monitoring of total immunoglobulin levels, G, A, and M, may allow recognition of those patients who are at higher risk of not responding to vaccination and of being unprotected from prior vaccinations, and hence the need for revaccination or administration of boosters. Rejection risk is a theoretical concern in the transplant setting. The viruses themselves, such as adenovirus and influenza B virus, are known to incite rejection. So vaccination against them may be protective. These are some of the general tenets of vaccination in the transplant patient. We have alluded to some already. Again, we have alluded to some. So these are the vaccines that are essential, of great interest in the renal transplantation, including hepatitis B, hepatitis A, the pneumococcus, influenza, very important. But the other is also coming, which we are all aware of in childhood. And the adult who has not got them in childhood, I should ensure that they get them well before they go on to the transplantation. The recommended vaccines after transplantation include DPT, hepatitis A, hepatitis B, pneumovax, inactivated polio, influenza type A and B, meningococcal vaccine, and typhoid. The contraindicated vaccines are varicella zoster, BCG, smallpox, intranasal influenza, live oral typhoid, measles, mumps, rubella, oral polio, yellow fever, and live Japanese B encephalitis virus. So these are completely contraindicated because they're live and they'll cause trouble in the immunosuppressed patients. So don't touch them at all. Yellow fever, particularly, as countries insist on them, you as a nephrologist must write a letter saying that your patient is exempted from yellow fever vaccination because he's had a transplant and is immunosuppressed. This will also apply to the patients who is traveling out to get a transplant, because at that advanced stage of chronic kidney disease, they're already fairly immunosuppressed and will not tolerate these live vaccines. I'll probably not go into too much detail on hepatitis, on the specific vaccines. So the concerns for hepatitis B is that the response after transplantation varies greatly. The titers decline more rapidly than usual, even in those who develop protective levels of antibody. The booster doses produce suboptimal responses, and hence emphasis on the value of pre-transplant immunization really becomes important, because you give it after transplant and it will really not work that well, and your patient will remain at risk. The ideal time to administer the hepatitis B vaccine is before the onset of end-stage renal disease. We need protective antibody titers of more than 10. And if it is not there, they should receive hepatitis B revaccination. It's preferable that vaccination be administered at the times of less intensive immunosuppression, which is after the past 3 months of kidney transplantation. More on hepatitis B. Protective responses to hepatitis B vaccination post solid organ transplant varies widely from 17 to 89%. In view of the low immunogenic response, there's been an interest in accelerated vaccination schedules, although they have not been studied in kidney transplant recipients. So the titers for the antibody, protective antibody is important, and they show a rapid decline post-kidney transplant. So they should be checked every 6 to 12 months, and booster doses given in the transplant patients. These are the dosages and the routes of the, but we have already referred to that in the chronic kidney disease patients. And the factors associated with decreased antibody response are anemia, hepatitis C co-infection, the elderly age, obesity, and iron load state, overload states are important. So adjuvants can also be used, as we have mentioned already. Erythropoietin, interferon gamma, granulocyte, macrocyte, colony-stimulating factor have been used, but data is not adequate. The pneumococcal vaccine, as I said, it is a real shame having a patient be repeatedly admitted for pneumonia following kidney transplantation, when all you need to do is to give that simple pneumococcal vaccine. So we vaccinate with both 23-valent polysaccharide vaccine and the 13-valent conjugate vaccine. And it's safe in the kidney transplant patients. Both are inactivated vaccines, and the schedule of immunization with the vaccine is as per recommended schedule for general adults. If a patient received the first dose of PCV13, it should be followed by PPSV23 at about 8 weeks later. If a patient has received the PPSV23 in the past, a PCV13 dose should be administered after at least a year only. So more about pneumococcal vaccines in children. So this is extremely important in adults. Patients who have not been previously vaccinated should receive a single dose each of PCV13 followed 8 weeks later by PPSV23. Influenza vaccination, extremely important, because we are all aware of the problem of influenza being followed by a pneumonia, which is a major cause of mortality in the elderly and in the immunosuppressed patients, including HIV, including post-kidney transplantation, chronic kidney disease. So we really have to pull up our socks in this regard. Two common vaccines variants exist: the live attenuated vaccine and the trivalent inactivated vaccine. LAV and its intranasal variant are contraindicated after renal transplantation because it's live. So among the various flu vaccines, the injectable inactivated vaccine is safe in kidney and transplant patients. If an end-stage renal disease patient received a live attenuated influenza vaccine, should not be immunized preferably for the next 4 to 6 weeks, or at least for not less than 2 weeks. After kidney transplantation, routine annual inactivated influenza vaccine administration is recommended in all transplant patients. So the underlying issue is do not use the live vaccine. Use the inactivated vaccine, which is quite safe and can be used fairly easily. Immunogenicity of the influenza vaccine in kidney transplant varies. The variation can be attributed to the vaccine strain, the time after transplantation, the immunosuppressive regimen, the net state of immunosuppression of the recipient. For example, patients on MMF. Have a lower seropositivity rate, so that should be considered for the influenza vaccine. Triggering acute rejections, as have been feared, but studies have not substantiated this allegation that influenza virus, influenza vaccination can cause an increase in acute rejection. So in large registry data, influenza vaccines used in transplant recipients was associated with lower rates of viral graft loss and death. However, use of adjuvanted influenza vaccines has been shown to cause a rise in anti-HLA antibodies, but not acute rejection episodes. It's therefore not advisable to use adjuvanted influenza vaccines in kidney transplant patients. The varicella vaccine is a live vaccine, and this is contraindicated, so don't use it. It's also contraindicated in the kidney transplant patients. So you give it before, in the early stages of chronic kidney disease, not following transplantation. The human papillomavirus vaccination is an important one for the young girls, and ensure that they get it before, in the early stages of chronic kidney disease, and not after transplantation. Hepatitis A vaccination is important. It's an activated subunit vaccine that can be administered in high-risk individuals or with the potential to contract the virus from food, water, body fluids of infected individuals. The vaccine is safe and well tolerated in renal transplant patients. A 6-monthly 2-dose regime is recommended. Hemophilus influenza vaccine, so it's important in splenectomized individuals and sickle cell disease patients who are at high risk of getting this infection. It's reasonable to consider immunizing CKD patients with sickle cell disease and those undergoing desensitization protocols, particularly for ABO incompatible transplantation. In contrast, children should receive the vaccination as a routine schedule, and the immunogenicity can be assessed by follow-up of HIV antibody titers. Meningococcal vaccine, kidney patients are at risk of developing meningococcal infection. Those who undergo desensitization protocol transplantation, particularly ABO incompatible transplantation, should seriously consider meningococcal vaccination, tetanus vaccination. The toxoid should be kept, inactivated tetanus toxoid should be kept updated. So these are important vaccines: the diphtheria, tetanus, and pertussis, inactivated vaccines, and is recommended for all prospective pediatric renal transplant recipients. Tuberculosis. Countries in Asia, Eastern Europe, Middle East, Africa, South America have universal neonatal BCG vaccination. In contrast, North America, United Kingdom, Australasia, Western Europe do not practice routine BCG vaccination due to low prevalence of TB, so recommending it only to those neonates and children considered to be at higher risk than the general population. This has been postulated to be one of the reasons why we're more protected against COVID, but that's still hypothetical, and nobody is sure that this has been of great help in our region. Rabies vaccine must also be mentioned. Typhoid vaccine, cholera vaccine. The oral live cholera vaccine is contraindicated in kidney transplant patients. The killed and subunit vaccine is considered safe in immunocompromised patients, although its immunogenicity is unclear. Yellow fever vaccine, very important because we are always told to write letters, is live attenuated yellow, is contraindicated. Although a case studies have suggested that there was important side effects in that cohort of solid organ transplant patients, travel to endemic regions is best avoided. If unavoidable, suppliers should take precautionary measures and carry a letter from the physician stating the contraindications of vaccination with a stamp approved yellow fever immunization center. However, some countries may still deny entry without immunization. It's one of those things that you must have at the airport. So the nephrologist letter then becomes very important. Measles, mumps, and rubella, live attenuated vaccine, and contraindicated. Japanese encephalitis virus, Again, the newer killed inactivated vaccine is safe and recommended in 2 doses, but the older live virus is contraindicated. Cytomegalovirus, this is where you say, I wish, because if there was a vaccine against cytomegalovirus, a lot of our problems will be sorted out. So there's an unmet need for developing treatments with new mechanisms of action, including effective vaccines against cytomegalovirus, as we are all aware in the transplant community of the ravages that this disease causes. So we are still left with antiviral therapy, currently used for CMV prophylaxis in solid organ transplantation recipients, is associated with adverse effects, including neutropenia. So caution is required. In summary, patients with end-stage renal disease after renal transplantation are a distinct cohort that carry an increased risk of common infections, potentially catastrophic complications such as infections, as well as reduced immunogenicity following immunization. In general, all immunization-related details should be obtained prior to enlisting for renal transplantation. Any planned vaccines should be administered in the pre-transplant phase at least 4 weeks before the kidney transplantation. While inactivated vaccines are considered safe beyond the first 6 months after renal transplantation, live vaccines are contraindicated throughout the post-transplant period. The reduced seroconversion rates and faster antibody clearance in these patients mandates regular screening for antibody titers and administration of booster doses when necessary. And lastly, the following general principles may apply to immunization in transplant patients. The efficacy of the vaccination, as measured by antibody responses, is usually decreased compared to the normal subjects. Effective protection from vaccination can be lost at any time. Safety profiles are modified, and specific complications such as rejection and graft dysfunction exist, at least theoretically, and live attenuated vaccines are usually contraindicated. Immune response is best when the vaccine is administered prior to the start of immunosuppression. And that's the end. I exceeded my time a bit, but thank you for listening. This is a topic that we really have to come to terms with, because at least in Kenya, we are nowhere where we are supposed to be. So let this be a clarion call to everybody in the dialysis and transplant field, that these are things that must be done. They're not optional, they must be done, so as to prolong the life of your patient, give your patient a problem-free period, instead of being readmitted day in, day out, endlessly. Thank you.
There are a couple of questions. One is from Jen Wangare, who is asking, the patients might need to travel and Yellow is a required travel vaccine. How is that handled then? Because being a live vaccine and it's contraindicated, and some of these patients will need to travel and they can't get the vaccine. How do you handle that? I know you mentioned it in your lecture, but maybe you can.
Let me just reiterate it because that's important. They need a letter that should be written to say that the patient is exempt from the yellow fever vaccine. The patient going for the transplant is in end-stage kidney disease and is immunocompromised. The patient who has had a transplant and is going for review, for example, to India, is immunocompromised and should not be given the yellow fever vaccine. So the letter is normally accepted. So always insist that you get a letter which is stamped and will enable the patient to reach where they're going.
And then we have a number of questions from Jane Reddy. The first one is, in facilities where the vaccines are available under the usual vaccination schedule, especially for the children, do the dialysis patients have to pay for the vaccine, or is it free vaccination?
I think the dialysis system the vaccination system in our country is mostly, for children it's free, but for adults, I'm yet to be told that it is free. There was a time I was head of the renal unit in Kenyatta National Hospital, and getting free vaccinations was extremely difficult for patients. Extremely difficult.
It's not free.
But these are cost-effective procedures, so that the act of actually giving the vaccine will save the patient a lot of money in terms of serious complications.
If I may ask, do these vaccinations, are they available in the general hospitals, the public hospitals, or do you have to go to the vaccination and travel clinics to get them?
Are they available in the general hospitals? Indeed, in the renal unit at the hospital, we have a system of vaccinations, but the problem is the apathy, the lack of seriousness with which you take it. And I hope that this talk will be a clarion call to end this apathy, because it is totally unwarranted and leads to unnecessary mortality and mobility in these patients that we care for so much.
And then another question is, what is the hepatitis B vaccination schedule for a health worker?
These are normal people, so you just give the 3 doses without a problem. But there's a transplanted patient and the chronic kidney disease patient, you give the 4 doses at the enhanced dose of 40 instead of 20. So higher dose and longer periods.
If I may ask, in your case, especially like in the renal units, do you vaccinate all your staff when they join, or with all the 3 doses, or do you check their titers before you revaccinate them?
As I said, there's a wide hiatus between practice and what is required. And a lot of this is economic, and I think it's on us to really put a foot down to ensure
what happens in Kenyatta? What happens in Kenyatta, being a leading hospital?
The vaccines are available, the people should go and get it, but sometimes we do not everybody gets it.
And another question from Jane Muridi as well, quite useful questions. If one doesn't complete the hepatitis B vaccination regimen, should they do the antibody titer first before revaccination?
I think the important thing, if one does not complete, is to probably just revaccinate, because the titers will probably be not adequate. So you probably just revaccinate.
Maybe I can share that, because from the lab side, what we normally do is we'll test both for hepatitis, the antigen to confirm whether somebody is actually infected or not, and then also do the antibody titers. If the antibody titers are sufficient, then they don't need to revaccinate. But if you're not able to do the antibody titers, then the recommendation from WHO is that you give all the 3 doses. And in fact, somebody else has also asked, an anonymous attendee, who says, what is the percentage of doctors who have protected antibodies from the free screening that we did at Lancet? We did some screening of more than 600 healthcare workers. And what I can say is up to 35 to 40% of them had insufficient titers. So,
unfortunately, tell us, what is the cost of the antibody tests?
It's basically a serological test, just like ELISA, costs about 2,000 shillings, but all healthcare workers get a 50% discount. Yeah. And in fact, what I can also comment is we see insufficient number of doctors and healthcare workers testing themselves. The recommendation is to test every 5 years at minimum. And then the other bit also is we don't see renal dialysis patients being tested for their titers, unfortunately. I don't think it's picked up. And actually, it's not a very expensive test, which I think in a place like Kenyatta, the cost can even come down to less than 500 shillings with volume. So probably it's something to consider in most of the hospitals to have it as a routine, because as you said, they should be testing annually, and for the doctors every 5 years. I don't see any other questions. I think all of them have been answered. Any closing remarks, Dr. Anthony Were and Dr. Walong?
All I can say is that I wish this becomes a turning point as far as the dialysis units all over the country are concerned, because Kenyatta is the main training ground. And when they don't see certain things being processed in Kenyatta, when they go out there, they end up doing exactly what we do with that slow foot that should end, hopefully, with this talk, and that vaccination will be taken extremely seriously from now onwards.
100%. Walong?
Right, thank you very much once again. The take home is that the autopsies has shown us a lot, and we would like to have it integrated in specifically in adult medical care. it's definitely a difficult area, needs a lot of time and effort, but the efforts do pay off at the end. For example, developing policy on infectious disease prophylaxis, management, vaccination. It will be an important area to obtain the data needed to justify a lot of these practices as well. Thank you. Right. In this, our inclusion criteria for now, because we are very interested in infectious disease, especially COVID-related mortality, we would like all these that are, these mortalities, if they occur in these centers, that's in Nairobi, we have Mbagathi Referral Hospital and Kenyatta National Hospital, then Kisumu and Siaya. So the nephrologists who are working here, we would like them to be sensitized and to refer the cases, and also to participate in meetings where we discuss the cases and assign causes of death, because it's a diagnostic process we have to align all these features that we see with ICD-10. So we definitely, especially now that we'll be looking at the kidney, we'll be interested to hear what opinions the nephrologists have during these decode meetings.